I would like this session, the topic of this session, all about the tips and the tricks for the complex PCI. I'm Hong from Severance Hospital, and my co-moderator, Dr. Otsuji Sensei, and there is several panelists, Dr. Erglis, and Dr. Hahn, Dr. Hamazaki, Dr. another Hahn, and Scott Harding, and Dr. Jang, BK Kim, and Dr. Ho Lam, and Mike Lee. I will introduce the first 1, 2, 3, 4, 5 present, and we will have a 20-minute discussion, and the master's cases will be introduced Dr. Otsuji, and we will have a discussion. Okay, first one is how to define a complex PCI in your PCI practice. This topic will present Dr. Mamas from England. Okay, Dr. Mamas, please.
So, thank you for the nice introduction. I look forward to a great session. I'm going to start by a question. Put your hand up. How many of you do complex PCI? Go on, the panel. I mean, do you guys not do complex PCI? Okay. How many of you can recognize a case of complex PCI if I show it to you? Well, let's see. Scott, can you recognize it? Okay, I'm going to show you that actually you can't. So I'm going to show you in this lecture that you can't. So I have no conflicts of interest. So first and foremost, why is it important to define complex PCI? Well, the reason it's important is because actually being able to define what's complex guides our practice. So for example, the antiplatelet therapy, in complex PCI, antiplatelet therapy is different from non-complex PCI. Now you may say, well, okay, complex PCI, we may not be able to define it easily, but if we see it, we can name it. So this is the duck-billed platypus. If I was to say to you, what is a duck-billed platypus? You may all struggle, say, oh, well, it's got a beak, it's got fur, it lays eggs. But if I show you a picture, you'll immediately be able to recognize it. So is that true? Can we recognize complex PCI when we see it? Well, the answer is no. So this was a survey that we undertook with EAPCI, 270 interventional cardiologists, mean experience of 15 years. So this is 15 years post-finishing their fellowship. And we showed them 4 case scenarios. And we asked them, is this complex PCI? And that's why I asked the question at the start. And actually, there was very poor agreement. So the R-squared was something like 0.2. So very poor agreement amongst very experienced interventional cardiologists, irrespective of seniority. So even people that had finished their fellowships 25 years ago could not agree on what complex PCI was. So we made it slightly easier. We said, okay, maybe if you show cases, it's not so straightforward. Why don't we just look at individual factors and say, how important are individual factors in representing risk? And again, you can see that for many factors, there's not really great agreements. I mean, for some factors, like impaired LV function, everybody agrees that that's quite important. But there are other factors, like the presence of diabetes, the sex of the patient, the risk of procedure-related MI, that actually many people don't agree on whether this is an important factor or not. And so there's many ways of defining complex PCI, and some of them have really just focused on anatomical complexity. And one of the major descriptors of anatomical complexity, of course, is the syntax score, which takes into account things like dominance, whether there's a total occlusion, whether there's a bifurcation, whether there's tortuosity, calcification, and so forth. But then when we look at the utility of this in terms of guiding, whether we should even do the PCI, actually, it's quite poor. So if you look at this individual patient meta-analysis of patients undergoing PCI for left main versus coronary artery bypass grafting, complexity, as defined by syntax score, actually doesn't really help us guide in our decision-making process because actually it doesn't impact on clinical outcomes. We may also say, well, okay, the ESC has defined complexity another way by looking at lesion characteristics rather than coronary anatomy. So, they say there that if you use 3 vessels treated or 3 stents implanted or bifurcations with 2 stents or long stents or CTOs or rotablation, left main, saphenous vein grafts, these is complex PCI. My problem with this is that, this group of lesions is very heterogeneous. And to give you an example, you have a left main, this ostial left main. This is the sort of case that you'd be quite happy to leave your fellow to do. And yet you've got this horrible one, subtotally occluded, bifurcation, left main, heavily calcified. And of course, these are very different beasts. And yet we're saying that these are complex PCI, and clearly they're not. We also, if you think about lesions, even, the lesion on the right, this lesion, yes, it's complex, but there's a great difference if you do this procedure in a 40-year-old who's otherwise well versus a 90-year-old with diabetes, an amputated right foot with a previous history of stroke. Clearly, they're 2 very different scenarios. And we have ways of measuring patients' comorbidity, which again is one of the factors that, in my view, determines complexity. So here we have a risk score that's been validated, the Charlson comorbidity score. We were the first to validate it, certainly for long-term outcomes in PCI from the Nabori 2 study. And you can see that, up to 5-year outcomes, comorbidity burden is associated with factors such as 5 years, cardiovascular deaths, MACE, and so forth. And so when you sort of then come back to why are you actually trying to define complexity? And the reason you're trying to define complexity is to identify risk. And so that when you identify risk in patients with high risk, you can then personalize their treatment, whether you use more potent antiplatelets, whether you go upfront with LV support, and so forth. And so what my point is actually complexity is subjective. It's when I showed all those figures initially, and everybody was saying, yes, it's complex, no, it's not complex, it's slightly complex. Whereas risk, by a risk score, isn't subjective, it's entirely objective. And that's what we set out to do in the United Kingdom by developing a complex PCI chip risk score. And we used UK National Registry and developed this chip score. And this chip score looked at the prognostic relationship between individual patient-level factors, lesion-level factors, and procedural-level factors to develop a score. So we then defined a chip score of 5, which is defined as 5 times more than the MACE of a score of 0. And this score is very good in terms of defining risk of major bleeding, MACE, stroke, and so forth. And it's been validated. It's been validated by Mount Sinai in the US, which again shows very good discrimination of our CHIP score in their cohort. So I think in summary, when we're thinking about complex PCI, I don't think it's very helpful to think about whether it's a left main, whether it's a vein graft, whether it's a CTO. But we should think about it by risk. And risk is determined by clinical factors, procedural factors, and lesion characteristics. When thinking about complexity, we should use patient-centered, clinically relevant endpoints such as MACE to define complexity, rather than just looking at the angiogram and saying, this is complex, this is not complex. If I see something, I'll probably say, this is really complex. Whereas if a Manos Brilakis looks at it, he'll say, no, this is straightforward, it's not complex. I think with the exception of LV support, a single factor only has very modest impact on complexity. So in my view, when we're trying to think about complex PCI, we need to be thinking about it in terms of a validated risk score, number 1, in the context of multiple risk factors that are patient level, lesion level, and procedural level. And with that, I'd like to thank you.
Excellent presentation. We will move to the next topic. Next topic is the intravascular imaging guided complex PCI. Which one and why? The speaker is Dr. Kang from Asa Medical Center.
Yes, thank you. I'll talk about the role and the selection of the intravascular imaging for guiding complex PCI. Why do we need intravascular imaging for guiding PCI, especially in the complex PCI? Because all data shows the clinical benefit of the use of the intravascular imaging for guiding complex PCI. Professor Hong showed the data of the IVUS XPL in long lesion, and the ultimate from China in the all common lesion or reduced the MACE on guiding PCI with the IVUS compared to angiography. And in CTO, the CTO IVUS RCT that showed the benefit of the primary endpoint of cardiac death, MI and TVR, when used the IVUS compared to angiography only. And recently, Professor Hahn published a very big and important paper that renovated complex PCI that enrolled the patient with the bifurcation, CTO, left main long, multivessel ISL calcification, PCI, that showed clear benefit of the target vessel failure, and target vessel failure, excluding periprocedural MI, also showed the benefit of the over 30% when used intravascular imaging compared to angiography-only PCI. And also, there's no dedicated the RCT published yet for left main, but I showed that I've improved 10-year clinical outcomes in long-term in the left main registry when you use the IVUS-guided PCI for left main. And there are so many the meta-analysis, and this is the very new analysis that should enrolled every RCTs that showed the clear benefit of the cardiac death, MI, and TVR compared to the use of the intravascular imaging compared to angiographic-guided PCI. There are clear benefits when we use the intravascular imaging to guide PCI. There are clinical benefits. Then, how, and why the intravascular imaging improves the clinical outcome? Because it optimizes acute stent result. In the IRIS-DES registry, we selected the complex coronary lesions and divide the patients that undergo the IVUS-guided PSP, predilation, stent sizing, and post-dilation, and the patient who did not. 1/3 of the patients undergoing the complex PCI with the intravascular imaging guidance or not, and 1/3 did the IPSP, and 2/3 did not do that. And the IVUS-guided PSP group had a higher stent number and longer stent length, and the bigger stent diameter with a bigger final balloon size. And the clinical outcome was better in the patient who did the IPSP compared to no IPSP group. And it was consistent in the many the adjustment analysis. And the most important thing that was predictable for the clinical benefit was post-dilation. And this is very interesting thing that when we use the IVUS, we could apply bigger post-balloon with a bigger, higher pressure, so we could get the bigger MSA. So with IVUS, I can implant bigger stent with higher pressure post-dilation, but we know the vessel size, we can do it safely. And that small details post-PCI would make a long-term big difference. That's why I insist that we should use the intravascular imaging for guiding complex PCI. And which device shall we use? There are commonly two devices, OCT and IVUS. And OCT and IVUS use the different wave source, near infrared light and ultrasound. So actual resolution is different. And the OCT needs the blood contrast, and the IVUS can visualize plaque burden, and the aortosteal visualization is available. So the guideline recommends the 2A indication for the IVUS and both OCT. And the OCTIVS trial that we performed and presented last year that compared OCT and IVUS-guided PCI in all-coma patient and showed non-inferiority of the OCT-guided PCI. And we did the key subgroup analysis of the complex coronary arterial lesions. The complex coronary arterial lesion was defined as unprotected left main, bifurcation, aortosteal lesion, chronic total occlusion, and severely calcified lesion, ISL, and long and multivessel PCI. And the study outcome was the target vessel failure and maximal follow-up. Because this is a subgroup analysis, main analysis was performed in the age-treated population from the whole Octaves population, and cumulative event probabilities were estimated with the Kaplan-Meier method, and then outcomes were also compared with the use of propensity score matching method. And of the 2008 patients who were randomized in Octaves trial, the 1,400 patients was defined as complex PCI, and 710 patients underwent, 719 patients underwent OCTI PCI, 756 patients underwent IVUS-guided PCI. And key baseline characteristics was not different between groups, but the previous PCI history was more prevalent in OCT-guided PCI. But the unprotected left main disease was more common in IVUS-guided PCI. There could be some crossover because this is age-treated analysis. And mean syntax score and median syntax score was a little bit higher in IVUS-guided PCI group. And PCI approach modality using the mainly drug-eluting stent and was not different between groups. And total amount of the contrast media used was higher in OCT-guided PCI. However, the total PCI time was short in OCT-guided group. And procedural outcomes by angiography was not different, but imaging-based the evaluation, by the definition, the procedure success rate was higher in IVUS-guided group. And procedural complications was lower in OCT-guided group. And cohort QCA analysis did not show significant difference between groups. And primary outcome of the target vessel failure at the median 2-year of follow-up showed no difference between groups with a hazard ratio 0.87. And this is a detailed list of the secondary outcomes, that there was one difference of the target vessel MI that was lower in OCT-guided PCI group, mainly driven by periprocedural and also spontaneous MI. And also in the propensity score, the overlap weighting population and IPTW population showed consistent result. Subgroup analysis by the anatomical factors did not show no difference, just excepting for the in-stent stenotic lesion, they showed a little better the clinical benefit in the OCT-guided group. However, there are some limitations because the observed number of the primary endpoint event was lower than expected, and there was no masking, so there can be some selection bias. So in the subgroup analysis of the Octaves trial, we concluded that the OCT-guided PCI showed a similar risk of the target vessel failure as compared with the IVUS-guided PCI for guiding complex PCI. And this is my practical view that in my the personal practice. For left main or ostial lesion, I prefer IVUS because it can visualize better the ostial lesion. And the bifurcation, two things all do work very well, and OCT shows very delicate and beautiful images. Long lesions, OCT save time. And CTO, sometimes we cannot visualize the distal vessel, and IVUS is very helpful. ISR, OCT can visualize better for the calcification and stent, and it's very useful. And some patients with a renal dysfunction or the heart failure, I prefer IVUS. This is my conclusion. Thank you.
Okay. Next presentation is the calcified nodule in the complex PCI. They are all the same, and how should we treat? This topic will be presented Dr. Maehara from the USA.
Thank you. The calcified nodule is defined as the accumulation of small calcium fragments on top of the very dense calcium. By OCT, sometimes we confuse compared to the red blood cell because of the strong attenuation. That's because of the fibrin inside of the calcified nodule. And when we compare the patient or lesion which having the calcified nodule with without, the main characteristics in the patient who had the calcified nodule is old and more likely hemodialysis And when we look into the lesion, the calcified nodule is large calcium, and hinge motion is more severe. So those are the characteristics in terms of the patient and the lesion. Among the calcified nodule, if you compare the ACS patient versus stable patient, the calcified nodule in the ACS patient is more likely thrombus together. That's most likely indicating the eruptive type of the calcified nodule. If we include all severe calcified lesions which require the rotablator, with without calcified nodule differentiate very different future outcome. If we don't treat the calcified nodule, which because of the non-significant, the eruptive calcified nodule had worse outcome compared to this type of the protruding calcium. So to answer what type of the calcium is bad when we treat, we try to answer using the St. Francis Hospital database. That's including almost 10,000 OCT. Out of those, pre- and post-OCT in de novo lesion, which include 4,000 patients. And then one of my fellow, he reviewed everything, and then finally he could find calcified nodule. The prevalence of the calcified nodule was 5.9% per vessel, 7.3% per patient. And that's including 272 calcified nodules. About half is so-called eruptive, and half is non-eruptive. So this is a very typical picture. Either eruptive or non-eruptive, angiographically, you see typically this type of the radiolucent opacity, and which quite consistent in both type. But when we look into the OCT, the eruptive one, you see the irregular surface, and that looks like disruption of the fibrous cap. When we look into the non-eruptive, the surface is already covered by the fibrous cap. That's how it looks different. When we treat by stent, typically the eruptive one looks like redistribution of the calcified nodule and making the relatively good stent expansion. On the other hand, non-eruptive one, they are stretching the non-calcified nodule site and then just pushing the calcified nodule. But typically, when we look into the calcified nodule, what is important is non-calcified nodule site. And many times, actually, those segment is non-calcified. And even though non-eruptive, the non-calcified nodule site is non-calcium, they are okay expansion because stretching this site. What is the distribution? Calcified nodule is most frequent in the proximal LAD or mid-right. But eruptive one is more frequent in the mid-right coronary artery because that hinge motion is more compared to the other segment. And interestingly, as I said, the eruptive calcified nodule, they are redistribution of the calcified nodule when we compare the pre and post in terms of the surface arc. And it looks like, obviously, they are reprotrusion, redistribution on the surface. That seems to be the mechanism of the stent expansion. And then we ask, what is a predictor of the stent expansion in the calcified nodule? Compared to the non-eruptive, and the eruptive one is better because they can make the redistribution. But what is important is actually additional factor. Number one, circumference of the calcified nodule, meaning big calcified nodule is bad compared to the small calcified nodule. The other three is very important, meaning non-calcified nodule circumference, how much calcium outside of the calcified nodule, that's very important, indicating the worst stent expansion, and minimum calcium thickness in the non-calcified nodule site, that's very important. If that is thicker, that's going to be the superior expansion. And finally, negative remodeling together with the calcified nodule is causing the poor stent expansion. So I'm going to explain a little bit more what this meaning. So this is the data outside of the calcified nodule. This is all more than 270 degree of the calcium. We're picking up about 240 cases. And then all cases was treated by balloon and stent only. We ask, what is the most important factor to predict the calcium fracture? It's minimum thickness of the calcium. So if the minimum thickness of the calcium is thinner, we can make the good fracture even the balloon stent only. But if that is thicker, we cannot. So those are the very important. And because of this, we revised the calcium score. And outcome is really the minimum calcium score is very important. Additionally, this is a type of the case. You see the mid-LED, it's calcified nodule, which looks like the non-eruptive. But when we look into the vessel size at the site of the calcified nodule, which is much smaller compared to the distal, this indicating negative remodeling. When you have this type of the pattern, even the total arc of the calcium is not too big, this is bad stent expansion. Because of this, we did the orbitally, even though the small calcium, we ablate, and we see the nice reverberation that's indicating the good orbitary effect. At the end, we see the calcium fracture, even the such small calcium, making the good stent expansion. So we ask separate question. If the calcium is less than 180, what is the predictor of the poor stent expansion? That's a separate cohort. And one answer is under expansion is very rare, which is only 3.6%. But the predictor is eccentric calcium, including the non-eruptive calcified nodule, or negative remodeling, and typically in the mid-LED. So if those together, they are poor expansion. So this is a kind of a typical pattern in the calcified nodule, non-eruptive type. If that is together with a negative remodeling, actually this is poor expansion. So altogether, what is the important factor to predict stent expansion in the calcified nodule is a pattern, but also the other factor outside of the non-calcified nodule site. However, when we look into the outcome, that's completely opposite, meaning eruptive calcified nodule had almost 2 times worse outcome compared to non-eruptive. The reason was this. You see the nice eruptive calcified nodule after the treatment, you see the nice stent expansion, but patient suffered reprotrusion of the calcified nodule in the stent only 5 weeks later. So that's phenomenon we see more and more. And then we ask, what is the independent predictor to predict the future event in the calcified nodule is eruptive compared to the other? Additionally, circumference calcified nodule, meaning big calcified nodule is bad, and also the hinge motion is higher, that's more likely causing the event, because probably they're shaking always and then making reprotrusion more in the eruptive calcified nodule. IVL may not be good, but there is some promising data. Their outcome seems to be better compared to the other modality. So to summarize, stent implantation deform the eruptive calcified nodule more than non-eruptive. Therefore, they have better stent expansion. But importantly, not just the calcified nodule pattern, we have to look into the non-calcified nodule site. Sinus calcium thickness, arc, those are the important, as well as the negative remodeling. And TLR at 6 months is much higher in the eruptive because they are going to reprotrude through the stent. In terms of the how to treat, for the stent expansion is still very important, so we have to be careful non-calcified nodule site. But to be honest, what is the best strategy to treat non-eruptive? We don't know the answer, so we really need more data to confirm whether orbitally or other factors make it better for this very difficult population. Thank you.
Very important data in regarding to the calcific nodule. Okay, the next topic is insight into the Rota and the super high pressure balloon and the optimal device choice in the severe calcific lesion. The presenter is Kambis Mashayekhi from the Germany.
Thank you very much. So those are my disclosures. So basically, we all know that the prognostic implication of calcified coronary artery disease is worst compared to non-calcified lesions, and we heard already now some great insights of OCT imaging, and we have this problem in our clinical practice with calcified nodules as well. But once you look here on pooled data analysis, the MACE rate is 20% higher in patients with coronary calcification compared to non-calcification. Therefore, it's very important to do a great plaque preparation. And we have basically 2 major modalities. One are the ablative techniques, as you know, and the balloon-assisted techniques. So why should we prepare calcified lesions up front? And you see that here, the stent, how it's damaged with on the polymer side. So we're preparing that to allow a successful stent delivery, to allow an adequate stent expansion, and also to prevent, for sure, the stent for thrombosis and restenosis. Well, the use of rotablation, those are a little bit older data from the last European expert consensus paper on rotational atherectomy, is between 0.8 to 3.1% in Europe. So up from 2015, we looked at our large database up to 2019. What we could see is an increase of the atherectomy device usage for debulking, as you can see, up to 6.9%. Well, those newer plaque modification techniques are supplementary. That's important to notice. As you see here, a very, very calcified left main stenosis, and with all the techniques that we have, the RCA, by the way, was included, rotablation, shockwave, and even super high pressure balloon. You achieve nowadays, in many scenarios, an amazing result, initial result, that would be not possible in the past. So we focused also on the new Rota Pro system. We didn't find any big difference. Well, it's the same, basically the same system, but we could prove that it's also safe, at least, and in-hospital MACE was a little bit tendential lower, but probably based on more experience that we have. When we focus on CTO and rotablation, which was about 6.9% out of nearly 2,700 CTOs, we found out that the tamponade rate, as you can see, is a little bit slightly higher. It's significant, 3.1% to 0.5%. So those are the much more complex lesions once we need rotablation during CTO. But interestingly, after 3 years, there's no difference in MACE rate compared to Rota or no Rota when you treat CTO PCI. And here you see the increase of rotablation usage up to 2019, going up to 14.1% with similar one-year MACE rates. So we also analyzed the sex-based difference. You know, sex-based difference are sexy nowadays, and we know that women have almost worse outcome in PCI, but we didn't find any difference in the rotablation cohort when we compared female versus male. Interesting is also to look at the low ejection fraction cohort or the reduced ejection fraction cohort, and here we could see slightly in-hospital difference in MACE rate compared to conventional PCI or those that we had to do rotablation. But again, no difference after 1 or 3 year MACE rate. For sure, the procedures were much more complex, as you can see, 100-minute procedural time versus 42, the fluid time 39 versus 16. So much more complex procedure once you need the Rota on top in an impaired LV function. Well, there is a beautiful paper out, the ERPCI clinical consensus statement in collaboration with the ERPCI group, and you see a very nice flow chart as well, bringing you up to Rota, and finally, after you put your stent, you still might need some post-dilatation with non-compliant super high pressure balloon or even lithotripsy, and that brings us to the next topic, the usage of the ultra high pressure balloon. You see here a nice lesion with NC balloon, which is not expanded up. Then with 50 atmosphere, the balloon cracked the calcium. And this is an OCT image, as you can see here. It's a deep calcification, and the super high pressure balloon makes nicely cracks, which makes better vessel compliance for the stent. There are some data out as well, and it's also FDA approved now since this year. And there was also a randomized trial focusing on super high pressure balloon versus scoring balloon. The primary endpoint was standard expansion index. There was not an inferiority. Both modalities are safe, and both have the similar result. So we also focused on that in our registry, in over 15,000 PCIs, and the usage is quite high, at over 500 PCIs with the super high pressure. So we only included the patient where the 30 atmosphere non-compliant balloon was inefficient to make a greater stent expansion. And probably what's interesting is that for you, if we need a very high pressure of 30 to 40, 50 atmosphere, the perforation rate, if it's circular calcium, is slightly higher, but not so significant. As you can see here, 1.7 versus 0.8%. And for sure, when we compare the heavily calcified lesion compared to the conventional PCI cohort, the MACE rate is doubled after 1 year. Probably of interest, the distribution of pressure that we have. So almost the 60% in the pre-dilatation has a pressure between 30 to 40%, but in the 15% we need pressures even higher, right? 45 to 50% to crack the calcium. And we observed some cracks starting almost at 40, and physiologically something at 45 happens as well. In some cases, 50 atmosphere can crack the calcification. If it's circular calcification, that's very important. So to conclude, ablative and balloon-based techniques are commonly used for plaque modification of calcified lesions are complementary. The utilization of atherectomy techniques is continually increasing, as you have seen and as you notice in your daily practice. I think the rotablation is a safe and effective technique, and it's resulting in an effective debulking of calcified plaques. The balloon-based techniques are effective for cracking deep calcified plaques as well. We have also newer technologies like the shockwave. I didn't go into the detail here. So clinical data of super high pressure balloon angioplasty demonstrating efficiency and as well safety as long as you use it in a concentric calcified lesions. Now finally, alt-block modification tools, as I said, are complementary and necessary in the armamentarium of every complex PCI operator. Thank you very much.
Very excellent presentation. The final topic is a management of a coronary perforation, microcast distal perfusion technique. The presenter is the Sojo Ishihara from Japan.
Thank you for giving me this great opportunity. So previous 4 doctors speak about very academic topics, but my topic is a very practical one. So the coronary perforation is uncommon but life-threatening complication. So we cannot experience many perforation cases, so that we should learn from others. To get hemostasis, as you know, long-time balloon inflation is sometimes served, and perfusion balloon catheter might be effective, but limited country we can use. And heparin reverse also sometimes effective, but it sometimes causes the slumps. And check the pericardial effusion is also important. And other options are covered stent and also surgical option, but that's a last option. I will show one case, weight 81 years old male, after bypass surgery, he had severe stenosis at the anastomosis of the circumflex. And during PCI, predilation after the stenting, we see the massive perforation like this. And immediately, we dilate the stent balloon and so occlusion. But after 10 minutes occlusion, still bleeding continue. And also it is difficult to occlude more long time because of the chest pain and ST elevation. So that we use a perfusion balloon. This is made from Kaneka company and Ryusei. And so, so that we can continue 20 minutes so balloon tamponade. So that after that we can get a good hemostasis like this. So this is a perfusion balloon. So there are some holes, a distal part and also proximal part, so that during occlusion at the bleeding site, we can get the distal perfusion like this. So this is very effective, but only maybe in Japan or very limited country we can available this perfusion balloon, so that in other Asian countries, we should use normal balloon tamponade. So long-time balloon inflation in large vessel is needed, but it sometimes causes serious ischemia. So it makes chest pain, ST elevation, blood pressure decreasing, and arrhythmia. And covered stent might be an option, but it is sometimes difficult to deliver. Or it have the high risk stenosis ratio. It's a so serious problem. So that I reported this method. So I will show another case. This is a 73 years old female after AMI, and an LAD lesion was progressive one, so that we performed PCI. And after putting the drug-eluting stent, still so some hedginess is shown. So that after post-dilation, but we dilated too much high pressure, so that indentation disappeared, but we saw serious perforation of mid-LAD. It's a serious situation. So in this situation, so my younger colleague so occludes the balloon with so at the point, but severe ST elevation and the chest pain occurs, so we cannot continue so long time balloon inflation. So that our technique is so put the microcatheter besides the balloon catheter, and also during the balloon inflation, we give the patient arterial blood via this microcatheter. So this is a microcatheter distal perfusion technique. So so we can see the ECG was so during occlusion ST elevation was shown, but so we can see the ST elevations decreased during giving the blood pressure, so distal perfusion. So after the 20 minutes, so balloon tamponade, so bleeding stopped, and also fortunately no pericardial effusion, and the patient could discharge. So I will show the schema of this technique. So first of all, after the perforation, so not for the distal perforation, but so this is good for the massive perforation. So after perforation, we should make balloon tamponade like this, so that fortunately, so bleeding stopped, but distal part is suffered with ischemia. So that insert the wire and microcatheter. So I recommend fine cross or such kind of normal, so general microcatheter is better. And after immediately, so soon decrease the balloon and advance the wire and microcatheter to distal part. And after advancing microcatheter, so open up the balloon again, and so leave the wire, and via microcatheter we inject the patient arterial blood, and so that we can perfuse distal part. So this is the image of this technique. So this is a guiding catheter for PCI, and so we can see that this is a microcatheter, and also this is a balloon catheter for occlusion. And we should puncture another site, radial, femoral, anywhere, okay, but it is important arterial site. And so from this arterial site to the microcatheter, we connect with extension tube and also three-way stopcock like this. So we should need a small extension tube like this. So we should inject by hand injection with a small syringe. It is important. So the patient blood pressure and out circulation is not enough, so that we should inject by hand injection like this. So some doctors ask, is it so possible to occlude the perfusion site, the perforation site? So if microcatheter is at opposite side or lateral side, it is okay. And if microcatheter is at the perforation site, this is almost okay. But if the microcatheter is near the perforation site like this, at that time bleeding still continues, so that we should change the location of the microcatheter. So it is not so difficult for expert doctors, so that once we retrieve the microcatheter, and once again advance one guide wire and also microcatheter, so we can change the location of the microcatheter easily. Twice or three times I examined in vitro, so that it is very easy to change the location. It's not so difficult. So this is the last slide, ladies and gentlemen. So microcatheter distal perfusion techniques are useful when long-time inflation is needed. So if it is not effective enough to stop bleeding, but during these techniques, we can consider and carry out other therapeutic options, cover stent, surgical options, or if you have the perfusion balloon, so you can correct, so we can one more puncture in the double guiding catheter ping-pong technique also. So anything we can carry out during this technique. So that in Asian countries, so without perfusion balloon, I want to use this technique. Thank you so much.
Quite new technique to treat the perforation. Actually, we already use the 5 minutes for the presentation regarding to the 5 presentation. We have a 15 minutes discussion regarding to the 5 presentation. Any question and comment?
Yes, I have a question to the Akiko. So thanks for the nice lecture. So usually the calcified nodule anyway it break over the calcium. So I have a question the terminology of eruption. Eruption might from some pathologic reason. So what do you think the mechanism of the eruptive or non-eruptive calcified nodule, and also what do you think the major determining factor is 2 different type of the calcified nodule?
Okay, I think nobody knows, but even because of the pathologists tell us, based on the one snapshot, they don't know what is the beginning, what is the end. But we have about 340 cases which having the both baseline and follow-up, 2 times OCT. And all the cases had the calcified plaque at the baseline, no calcified nodule. And then we see the 7% of the cases newly developed the calcified nodule at the second time. At the baseline, nothing, second time the calcified nodule on the top of the calcium. So that has to be something developed during the follow-up time. And then based on the pathologists, they tell us most likely they are fracture during the cardiac motion, and then rupture, the fibrous cap, and then protruding to the lumen. But when we look into the calcified nodule in the pathology, actually the nodular small calcium fragments is not only the outside but also the inside. So there is already some the nodular calcification inside of the plaque, and that's protruding based on the disruption. But that's all imagination by the pathologist. We don't know what's exact happening at the time of the event. But that's what I believe. And then when we're talking the non-eruptive, actually I would call this is healed calcified nodule, meaning at the beginning they rupture of the fibrous cap. And then because this is part of the fibrous cap rupture, there should be the thrombus on the top, and then the healing process similar to the healed plaque, and then we see the cap on the top. That's, I think, the major difference. And seems to be the non-eruptive one is old, and then because of the outcome after the device treatment is quite different.
I also have, I would like to ask to you, because I'm somewhat confusing, because non-calcified plaque is associated with underexpansion, right? And underexpansion is one of the most important factors affecting the clinical outcomes, but still, eruptive calcified nodule is associated with worse outcome, right? So that's why I'm somewhat confused. And do you have any insight regarding how to apply your findings to your daily practice? I mean, the medical therapy is more important for the eruptive calcified nodule than the technique for intervention, and calcified nodule is, for the calcified nodule, the technique is more important than medical therapy or something?
I think in terms of the medical therapy or best treatment, I don't think we don't know well. But I think that both type is really, the acute goal is really good stent expansion, no matter how it looks like the type of the calcified nodule. And then as I showed today, is really what's happening is non-calcified nodule side. And sometimes those are the severe calcium because calcified nodule develop on top of the calcium. So if you have the very severe calcium before and after, or other circumference, that's really making the difficult stent expansion. So I think to see the entire calcified plaque on top of the calcified nodule and then making the best effort to good expansion is the most important. That's number one. On top, because of the eruptive is going to be reprotrude, seems to be they are biologically more active based on the pathologist findings. And probably we need some medical therapy as well, but that I cannot mention too much.
Maybe if you're here, I will, a small question to you, maybe, yeah, Satoru. if I can ask also for a question, and I've seen Gary Means here, and then there is for so many years we do a lot of imaging. But do you think that it's also will be seen by other technologies like you know, non-invasive? Because actually for us it is most important before, maybe long before we are doing something. And do you think that it's new technologies like photon counting, CT or others will help us in this field?
I think so. For long time ago when I was in Japan, I was taking the CT by myself, and I took so many patients for the hemodialysis patient. And we see the calcified nodule in the lumen, and that's actually lower density or lower Hansfield unit compared to the other dense calcium. And I think we can diagnose by CT for sure.
For the fair opportunity to ask the question to the other topics from the panel.
I would like to ask a question, Dr. Kang. So thank you. Congratulations again for your excellent OCT-IVUS study. One of the important findings of the OCT-IVUS trial is the procedure-related safety events occurred less frequently in the IVUS group compared with the OCT group compared with the IVUS group. So is there any plausible explanation, or is any specific component of a safety event difference between the two groups?
Yes, there was some difference in the acute complication between two groups. However, it was. I think that it is not. Actually, we checked the detailed list, and it was usually without some dissection or some aortic closure, and they was well treated with additional stenting. And I think actually we thought in ourselves that it was by chance, because there's no big difference between groups. Yeah.
Okay, Dr. Kang, in the subgroup analysis, the only different subgroup that show better outcomes in with OCT was ISL lesions. Yeah. Could you explain more about the mechanism of the better outcomes in ISL lesion? With, there was some difference in procedural steps after IVUS or OCT in ISL lesions.
Yeah, actually we reviewed all the data with some ISL patients because it was the only lesion subset that showed the difference, but there was no. Because the number of the patients was small, then we could not find statistical difference between the IVUS and OCT of the treatment. However, in the practical view, we could find and we could discriminate the calcium and stent. In IVUS, we could not discriminate that too, but in OCT, we can discriminate that in further detail. And I believe that we could apply more the tailored therapy for that. So, but in the numbers and statistics, and there was no difference between the DS implantation rate and the DB implantation rate. There was no statistical difference, but I believe that there was some difference in detail.
Another question? Okay.
Mamas, great presentation. I completely agree with you. One of the biggest predictors of what's considered a complex PCI would be LV systolic function. Now, if you go further and beyond that, if you look at from the shock trial, Judy Hockman showed that the cardiac power output was actually the biggest predictor of mortality. And 2 days ago, they had a live case where prior to the PCI in a patient with low ejection fraction, the LV-EDP was 28. And we're proceduralists. We do a great job of procedure, but I think we could do a better job of optimizing these patients in terms of volume status. I think it's very important. Also, the right heart cath. And if you don't have the luxury of a right heart cath, looking at their IVC, make sure less than 2.1, making sure their pressures are down. So there's really no reason why we should be taking these patients to the cath lab until they're volume optimized. And look at their map. If they have a EF of 30%, but their map is, let's say 90, that's different from a map of, let's say, 70s. Any thoughts?
I mean, I agree with you in relation to that, and particularly when you think about which patients are likely to optimize optimized with LV support as well in such cases. So I can understand that in the acute setting you may not have time to do right heart caths and assess these more fully, but I think in the elective situation, I think there's really no excuse that people aren't assessing hemodynamics much more carefully than what seems to be the case in many procedures. So I think in these sorts of cases, measuring LVEDP, measuring, undertaking a right heart cath, and then really thinking about what the values mean and using that information for your case selection in LV support, I think is important.
Okay. So, comment?
I'd like to ask to Dr. Mashayekhi, Kambis. The response to the high pressure balloon of the calcified vessel is always unpredictable. So, and the vessel perforation is one of the most fearful complications we met during the intervention. And you showed that the real high pressure ballooning is still associated with a risk of perforation 1.7. I think it's not so low, it's enoughly high. So what do you think the role of high pressure ballooning in the era of IVL? And unfortunately, high pressure balloon, open balloon or IVL are not available yet in South Korea. So do you have any suggestion between the IVL and high pressure ballooning regarding the risk of perforation?
So to better interpret the data, you have to understand that those were only used when the NC balloon was not able to open at 30 atmospheres. Then we used the super high pressure balloon. So if the normal NC balloon did not open at 30 atmospheres, we used the super high pressure balloon. And we had the 1.7% in the non-dilatable lesion in perforation, which is, it is probably high, but it is lower than we expected. Once you use the super high pressure balloon, there are several things that you have to understand. One is that you should not use it in the eccentric calcified lesions. Or when you have a non-eruptive calcified nodule and you want to have the perfect stand expansion and you will go in with 50 atmospheres, you will have a rupture. That's very likely. And as well, what you also to understand is if you use this balloon on the very high pressure, often the wire, you cannot bring the wire off the balloon. So you need a second safety wire when you use this balloon, just instead, because if it might be a perforation, you have to have the wire already there and just retrieve the balloon, because you cannot, it's very hard at the 50 atmosphere to bring the balloon out of the wire. So regarding the shock wave, I mean, for sure it's a very effective and very safe therapy, as we know, but I don't know any data at the moment, at least showing that particular when the normal NC balloon does not open at the 30 atmospheres, how the perforation rate in shock wave is afterwards. But the shockwave is economically definitely at 4-5 times more expensive, but agree. I think the vessel compliance and the microfracture in the shockwave, it's the superior technology and probably safer technology overall.
Kambis, may I ask you actually the same thing, because I'm getting older and I'm afraid to use so high atmospheres. But it's a reality, because I have, that's why for me. I always remember a very good friend, Garcia, who says it's better sometimes first to cut the meat and then to cook, not to cook and then try to cut. But it's interesting. And what do you think? Because we also use those balloons, and of course, but the question is usually about balloon size. I mean, how you adjust the size, and do you think that we should better go for a bit smaller balloon and higher atmospheres, or really try to go medium to medium?
I mean, I think if you go, the worst thing you can do is to size the balloon too big, right? But some recommend 1:1, but if you're a little bit more conservative, 0.75, I think it's okay. By the way, regarding the effect, I've seen lesions were not dilatable with shockwave and with open-N. Vice versa, I have seen lesions not dilatable with open-N, but with shockwave. I also do not understand why, and the imaging did not help. But there are some scenarios where you need all the techniques, like I have shown in my case. So sometimes, I think they are complementary, and we always try to somehow compare the one with the other, right? I mean, if you take two atherectomy techniques like orbital and Rota, well, might make sense, but in the balloon and atherectomy, I have a certain concern to compare that because I think they're complementary.
Absolutely. For the fair opportunity, one more question or comment to the doctor for Dr. Ishihara.
Yeah, I have a question.
Last one.
Right. It's a really good technique. So I have two short questions. The first one is usually coronary rupture after stenting is multiple sided, so it's not easy to apply in that case. And also the second question is, what do you think the puncture of the microcatheter, proximal and distal, like a distal perfusion balloon? Needle.
Yes, I understand. So the first question. So detection of the perforation site is very important. I'm sorry. So it's very important. And so maybe the next question is proximal part. The microcatheter has a hole. At that time, of course, it might be effective, but I have never experienced that. And also the small lumen is relatively small, and the patient blood pressure is not enough to perfuse. So that maybe even in small hole, so I think so injection is more reliable. And so some doctors ask me, how much volume should we perfusion? So maybe in perfusion value of Kaneka, so the official data is 20 to 30 milliliter per minute. So that we can inject 20 to 30 milliliter if chest pain is existing, other than more. And if chest pains decrease, other than relatively lower volume, it's okay, I think. Is it the question? Okay.
How long does it take? Usually 20 minutes in your case? How long does it take for hemostasis?
20 minutes.
Yes, 20 minutes, but by twice. 20 minutes twice. So long.
Please. We have to move.
Okay, thank you very much. So we'd like to move to the second part, the master cases. The case one, the rotational atherectomy with a super high pressure balloon or calcified lesion. Dr. Jung-Yong Hahn from Korea.
Thank you, Chairman. Good morning, everyone. 70-year-old male patient presented with non-STEMI. He had a dyspnea exertion. His comorbidity was hypertension and moderate renal dysfunction. Echocardiography showed preserved LV ejection fraction 45% with hypokinesia in LAD territory. Coronary angiography showed significant stenosis in the mid-RCA with heavily calcification, the same finding. But the culprit lesion is located the proximal LAD. Subtotal occlusion was found with heavily calcification. I decided to perform elective rotablation for this lesion using 1.5 millimeter bore with the RPM of 1805,000. Two drug-eluting stents are successfully implanted from mid-LAD to left main, followed by post-dilation using NC balloon of 5.0 by 8 under IVUS guidance. Due to time limit, I would like to skip the IVUS imaging, but anyway, the angiographic and IVUS findings are satisfactory. I tried to fix a non-culprit lesion in the RCA. However, balloon dilation was not adequate, so I had to perform provisional rotablation using the same 1.5 millimeter bore. After that, I performed IVUS. In the IVUS, nearly 360 calcium was found, but crack was found with the reverberation, and MLD was nearly 2.0 millimeter. So I think the size up of rotablation would not be effective. So I performed further dilation using 3.0 NC balloon. The angiographically balloon expansion was improved. So I implanted a drug-eluting stent 3.0 by 24, but the stent expansion was not satisfactory. 3.5 20 milliliter NC balloon was performed for a post-dilation up to 30 minutes. Angiographically, this balloon dilation was not bad. However, in the IVUS, stent expansion was poor, so under expansion was found. In this situation, we do not have many options, especially in Korea. So I decided to perform super high pressure balloon, so-called OPN balloon. The size was 3.5 by 15 millimeter. This balloon is nominal pressure of 30. So I used the 40 ATM to expansion of this lesion. These are stent booster images before OPN balloon, after OPN balloon. The stent expansion was markedly improved, but however, Akiko mentioned the stent expansion was mainly done at the contralateral side of calcified nodule. I was happy with that, but after injection, I found micro perforation occurred in the stent site. Fortunately, the blood leakage was stopped after a brief period of ballooning. So it is the final angiogram is not satisfactory but acceptable, and IVUS images was done and which showed improved stent expansion. So under expanded site was markedly improved without any serious complications. I will skip this 2 slides. So my reflection for these cases are follows. OCT would be better rather than IVUS to understand the extension and the structure of calcium, even if the patient had moderate renal dysfunction. We can consider the size of a Rota bore. However, as I mentioned in my presentation, MLD after Rota ablation was almost 2.0 millimeter, so I don't think it is quite effective. IVL after Rota ablation would be a good option, but unfortunately, IVL is currently unavailable in Korea. Thank you for your attention.
Thank you, Dr. Hahn. So the next speaker is Michael, intravascular lithotripsy vs. coronary atherectomy for calcified lesions.
Dr. Otsuji, Dr. Hong, thank you so much, and it's a pleasure to be here today. This case is a masterclass of how not to perform PCI, and my only disclosure is that I did not do the index PCI. I did the second portion of the procedure. So this is a 65-year-old female with a history of diabetes and hypertension. She saw the interventions for angina. Past medical history includes coronary disease, that's plus 4-vessel cabbage. In her right coronary artery, she had a vein graft, which was known to be occluded. So she went to the cath lab. And what you see here, number one, you see dense calcium in the prox LAD. You see a focal stenosis in the RCA. In the vessel, the reality is it's probably diffuse disease and probably explains why the vein graft occluded, because there's just poor runoff. So my colleague decided to treat this patient with a 2520 DES. No pre-PCI intravascular imaging was performed, no IVUS, no OCT. And I think that was a fatal flaw in that had somebody done OCT or IVUS, they would have seen that the reference vessel diameter was not a 2.5, and they would have identified severe calcium. So initially the patient did better, but at 4 months follow-up had recurrence of symptoms of ischemia, including dyspnea and exertion and angina. So was referred for coronary angiography, and that's where the patient was referred to me. So at 5 months, you could see here at the proximal segment of the RCA where the previously RCA stent was implanted, you can see there's a focal stenosis here. So obviously this would be a great time to use intravascular imaging to define the reason why this patient had in-stent restenosis. And OCT was very helpful to define what the problem was. First and foremost, you could see that there's no significant neo-intimal hyperplasia. The stent here looks like it's fully well expanded, but here, look, the stent is eccentrically expanded, most likely a calcium nodule. If you look at the longitudinal view, you can see there's an indentation. So what are some options? We could do high-pressure balloon inflation. We could do rotational atherectomy. So initially, I thought that let's just give it a try. Let's try an NC balloon at the correct reference vessel. We use the 3015 NC. You can see there's still a balloon that does not profile. So what are some other options? Well, I thought in this situation, rotational atherectomy or orbital atherectomy was not a great idea just because of the risk of a burr or crown entrapment. What I thought would be the best option would be to use intravascular lithotripsy. So think about inflating a balloon at 4 atmospheres. It's going to be very atraumatic. Just at 4 atmospheres, look how the balloon profiled. It got the stent fully expanded. Did an ideal job for this case. Post-IVL OCT suggested that the stent was well expanded. Now you've got a much larger MSA at 5.8 millimeters squared. You get a maximal stent diameter of 3.0. This is what the stent should have looked like on the index PCI. Now this is another example of a case that I saw. This patient was referred and had an angiogram and had a previous stent. You could see that the OCT shows in-stent restenosis, but unlike the previous case where the stent was not very well expanded, it looks like the stent's fairly well expanded. You see the struts here close to the EEL, but unlike the previous stent, this is a calcified neoatherosclerosis. So when you see this, the risk of burr entrapment is going to be very low. So I thought both options, whether it be atherectomy or IVL, would be a good option. In this scenario, I chose IVL, and you can see the classic fracture of the calcium, and subsequently you could get the full expansion of the intimal hyperplasia and get another DES. What sort of data do we have to identify the ideal treatment strategy for calcified ISR? Well, this is a small study, and really in the infancy of IVL, I think we need much more data. This is a single study, center retrospective study of calcified ISR at 1 year MACE, no difference between rotational atherectomy and IVL. So in conclusion, coronary IVL can be considered for ISR in the setting of stent under expansion due to severe calcification, on the understanding that it is used off-label. If you look at the Disrupt CAD series of trials, they did not include patients with ISR. But we need more data to determine the ideal treatment strategy for patients with severely calcified ISR. Thank you so much.
Thank you very much, Michael. So the next speaker is Dr. Werner from Germany. The cutting balloon or squatting balloon in severe calcified lesions. Dr. Werner, please.
Yes, thank you very much for the kind invitation. These are my disclosures. I want to report on a 73-year-old female patient. She was admitted to our chest pain unit due to unstable angina. She had a typical cardiovascular risk profile, and back in 2018, she had a PCI of ostial RCA, which was treated with a drug-eluting stent, 3.0 times 16 millimeters. So these are the setup shots. Looks like a quite unspectacular case. You see an intermediate in-stent restenosis of the ostial RCA. We had pressure dumping, and then we did an IVUS analysis with the Vigo Plus. This is seen here. You can appreciate that we have some in-stent restenosis of the ostial RCA and also some ostial calcifications. So the mechanism of the in-stent restenosis is stent under expansion with additional neointima and neoatherosclerosis, which you can nicely see here within the stent. So I think it's very important to dissect the mechanisms of in-stent restenosis, especially in the ostial RCA. This is a nice study in neurointervention showing that in most of the cases you have neointimal hyperplasia, neoatherosclerosis, and stent under expansion. Interestingly enough, in our case, it was all of the three mentioned entities, and this is important for the further treatment. So our strategy was, since we have moderate calcification and a lot of fibrosis, 4-0 vessel and a length of 12 millimeters of the lesion, that we go for scoring or cutting balloon because this is the preferred device when you have fibrosis or fibrocalcific atherosclerosis. So when you look at the data concerning modified balloon angioplasty versus control therapy with a normal balloon, you can see here a meta-analysis of 6 randomized trials, and it's quite disappointing to see that there was no major difference in major adverse cardiac events, and there was also not really a significant difference between the minimal stent area when using a modified balloon or control. Conventional balloon angioplasty. So when you look a little bit more into detail into the data, you see that there is maybe a slightly positive effect for the cutting balloon compared to the control therapy in terms of MACE outcome. So that's why we think that the cutting balloon with its small knives on the balloon is a little bit, maybe has some advantage in terms of you can amplify the force, you can crack calcium if you have some calcium, and therefore we decided to go for a 3.5 millimeter cutting balloon with post-dilatation with a non-compliant 4-0 balloon, and then putting a stent in. So this is the quite unspectacular lesion preparation with the Wolverine, and you can see the final result on the right. So the question in these cases is always, do you need to put another stent in, or do you want to treat it with a drug-coated balloon? And again, it's important to understand the mechanism of the underlying pathology. So here's data again from this Euro-intervention study. When you have a mechanical problem and don't put a new stent in, so stent minus means, for example, drug-coated balloon, then you have a very high rate of repeat revascularization. On the other side, if you have a mechanical problem and put a new stent in, the need for repeat revascularization is much lower. So that was the rationale to put another stent in and not use a drug-coated balloon. It's different when you have a biological problem, so isolated neointima formation, well-expanded stent, for example, then the drug-coated balloon has definitely its advantage. So for us, the key learning is that intravascular imaging, especially in stent stenosis, is the basic for planning an appropriate strategy. The cutting balloons are ideal for fibrotic and fibrotic calcified stenosis. Adequate lesion preparation is crucial for the final result, and the use of cutting versus scoring balloon may have some beneficial effect in lesion preparation, but we have very, very limited data available in terms of the perfect procedure. Thank you very much.
Thank you very much. So the last speaker of this session, Dr. Ziad Ali from USA, and evaluation of IVL fracture by histology, OCT, and micro-CT. Dr. Ali, please.
Thank you very much. My first disclosure is I haven't figured out how to do histology in a case. At least probably I don't want to. Okay, so this is the case presentation. This is a 70-year-old female who's very sick on anticoagulation, has atrial fibrillation, pulmonary hypertension, a lot of risk factors, but normal renal function. And this is the lesion. It's in the mid-right coronary artery. It's got clearly a tight stenosis, which has got the appearance of heavy calcification that's probably eccentric, may actually even be nodular. So the approach here was to perform intravascular lithotripsy. And so I'd just like to focus for you for a second here on how we do this. So you don't have this in Korea yet, but generally what we've moved towards is a guide extension upfront approach. This is a semi-compliant balloon. We swallow the semi-compliant balloon with the guide extension catheter, and then we deliver the IVL catheter, which is of course is thicker and stiffer, through the guide extension catheter. And then it's simple as unsheathing your guide extension catheter and starting to deliver your pulses. The first thing that you'll notice when you start to use IVL is there's no aha moment. There's no pop like there is with a non-compliant balloon. Instead, please look on the right panel. You see a very subtle but immediate change in the ratio of the wire, which is centrally placed, to the balloon expansion on the side. So this is a much slower progress. Then we perform pulse management. You should be moving the emitters throughout the calcified lesion. The reason is the maximum amount of energy comes directly from the emitter. You don't know whether it's going north or south, so it's important to make sure that both emitters face the maximum amount of calcification. This is optical coherence tomography afterwards, which shows multiple calcium fractures and multiple areas of lesion modification, which of course is the recognized mechanism by which IVL works. Here you can see calcium fractures at different parts of the vessel. You can see very deep calcium fractures, incomplete fractures, some dissection, as well as almost complete pulverization of a deep segment of calcification. Once this happens, the PCI becomes actually very easy. The DS crosses without gut extension catheter support. You have full angiographic DS exposure. And for all of you who have these, as Professor Hahn showed very nicely, all heavy calcification should be using advanced fluoroscopy, especially if you're using IVL. So make device detections, clear stent boost a part of your program, and I'll make a comment of Dr. Hahn's case perhaps at the end of this. Finally, as a result, we got a very nice result, complete and eccentric expansion with multiple fractures as we expect, and there's our final post-PCI result. And you can see the impact of the IVL is that actually the vessel spreads exactly where you create the fractures in multiple different places. Now, you all know the mechanism by which IVL works. It basically creates an acoustic pressure wave. That pressure wave enters into the artery and predominantly compresses, shears, and then pulls the calcium off of the outside of the wall in order for you to be able to modify it. We're really focusing on this area here, which is moderate to severe calcification. This is lovely work from Akiko and our group, which showed earlier that if you have on OCT 0.5 millimeter of thickness, 5 millimeters of length, and 50% of vessel arc, you're highly likely to be underexpanded. So think heavily about advanced lesion preparation. We showed in multiple studies that the mechanism by which IVL works is calcium fracture. We noticed that the calcium fracture usually leads to a doubling of the lumen area and after the IVL itself, with a tripling after you place the stent. Again, multiple studies which have shown even eccentric calcium can be fractured by IVL, and multiple studies showing that the mechanism is actually calcium fracture. Now, one of the very interesting things about when we looked at the CAD study was how many fractures you actually get and what are the characteristics of the fracture. So most patients get more than one fracture, allowing compliance in a circumferential way. Most patients get a full thickness fracture, and many of the fractures are in very deep calcification. But one of the very interesting things about the Disrupt CAD study was whether you got a fracture or you didn't get a fracture, the clinical outcomes and the stent expansion and area stenosis were the same. So how can this make any sense? This doesn't make sense at all. So when we took a deeper dive into this, we learned something very interesting, and that is that micro-CT is able to see that fractures occur by IVL in all different planes. There are chips, cracks, and breaks, and overall that leads to a crumbling of the calcium, and that crumbling changes vessel compliance, which is very different to the isolated fracture of a non-compliant or high-pressure balloon. Here you can see a calcified nodule which is broken into multiple pieces, and here you can see something very unique, and that is that OCT can miss calcium fracture, especially if the catheter emits the light exactly parallel to the fracture itself. So this very important study was conducted by us and Alok Finn, where we did an ex vivo experiment. And basically, we compared IVL to plain old balloon angioplasty, and we looked for fractures. And what we found in this very important micro-CT and histology study was that you often miss fractures by OCT. Fractures occur much more commonly using intravascular lithotripsy and much more in total number. The mean number of fractures in the plain old balloon angioplasty is 1. That happens at the thinnest point of calcification when you have a 270-degree arc. But if you have 270-degree arc of IVL, you have multiple fractures, on average 2.3. This is a take-home message. You'll notice that when OCT is performed compared to micro-CT, OCT completely misses these fractures. And the reason is the linear relation of the light. Two separate studies showed this basically at the same time. So approximately 50% of fractures on OCT are missed compared to micro-CT and histology. This is glycol methacrylated embedded or resin embedded stents, which show the full thickness fracture. You can see actually that OCT and micro-CT have a similar trend, but if you look at the correlation of OCT and histology, it's nowhere near micro-CT. Of course, we are unable to do micro-CT at the moment in human coronary arteries. So this ex vivo study basically showed firsthand histological examination comparing OCT and micro-CT, showed that micro-CT correlates with histology very well, but OCT does not. OCT as a result may underestimate the presence of calcium fracture and fracture depth. The take-home message is, if you see fractures on your OCT, the vessel is prepped. If you don't see fractures, it doesn't mean it's not prepped. So you need to rely on your non-compliant balloon and advanced fluoroscopy. Thank you very much.
Thank you very much for time. So we have 15-minute discussion time. So,
Dr. Ali, I'd like to one question. In your cases, how to achieve a maximal effect of the lithotripsy? Lesion preparation with the non-compliance balloon and then lithotripsy, or directly the lithotripsy? What is the...
So in our practice, so we have the highest volume of IVL use in the world. We've probably done 600 cases. This is what we've learned. Use a guide extension up front. Deliver your balloon, inflate at low atmospheres, 4. All you're trying to do is to scaffold the vessel and squeeze the intima. The intima is like a pillow, and if you put a pillow on top of a glass, you can't break it. You have to squeeze the pillow to reduce the impedance. That delivers the energy directly into the calcium. The calcium will then be fractured. After you've fractured the calcium, the best conceptualization is you have a plate that has multiple cracks, but it's not broken. So it looks just like a plate. You need the non-compliant balloon subsequently with high pressure to break the plate into pieces.
While we've got you there, I think one of the important things you might want to comment on is de-airing the balloon. I mean, that's a major thing. And I think you've learned a lot. If you have residual air in the balloon, which you often see, particularly with 120 pulses, right?
Mm-hmm.
Sometimes you'll start with no air, and then after you've delivered 4 treatments, all of a sudden there's air in the balloon. Do you want to make a comment about that? Because it's a really important point.
So critical point that Scott's making. The mechanism by which IVL works is to create gas. Gas over time, after you deliver multiple pulses, will create a bubble. Bubble is invariable in IVL. After 30 pulses, if you don't see a bubble, something is not right. You should be prepared to re-prep after 30 pulses. And all that means is turning off the stopcock, sucking back, counting to 5, you'll see the burp, you can turn back on and deliver it. We found that in our bench experiments, you reduce the amplitude of energy if air is inside your balloon by 40% and you reduce your fractures by 20%. The air is just like an airbag in a car. It absorbs all the energy.
Ali, so we don't have any experience of the IVL. So I have a question to the fracture site. So you can intentionally point and mark the fracture. Is meaning I want to reflect this calcification site. Is it possible with the IVL?
Yes, and it's absolutely critical. So while the engineers will tell you that there's no directionality to this device, there is 100% of directionality. You don't know which way the emitter is facing. The energy comes out like an upside down volcano, like an eruption. So whichever way the emitter is pointing, that is where the maximum amount of energy will go. So when you go on to advanced fluoroscopy, stent boost, clear stent, device detection, you want your emitter to be at the maximum segment of calcification. You want to deliver 10 pulses, then move your emitter just a little bit. Now what you don't know, because the emitters are diametrically opposing, they're 180 degrees apart from each other. So you need to make sure that your maximum calcium is actually hit by both emitters, because you don't know which one is directional.
Okay, so other question?
I'd like to ask to Michael Lee, Dr. Michael Lee. Thank you for your insight into the calcified ISR. But in my opinion, if we do rotablation to the calcified ISR, the rotablation would affect the stent strut. It will also ablate the stent strut, right? So because we cannot finely tune the depth of ablation during Rota ablation. So if we do Rota ablation for the calcified ISR, we need to place another stent to cover the region. But if we do the IVL for calcified ISR, we can finish the procedure with just DCB or just plain balloon angioplasty. And what do you think about, in my opinion, and do you have any tip to avoid stent stroke damage during the Rota ablation for the calcified ISR?
So in the setting of calcified ISR, I think, number one, the main thing is that you can use atherectomy, because when you have an eccentric calcium like a nodule, like when I showed you, my concern is that you're going to ablate the stent struts, okay? So number one. But if the stent's fully expanded, then I think you have both options. I mean, drug-eluting stents have clearly been shown to be beneficial. At the same time, DCB is also an option as well. I just think we don't have enough data to say one is superior than the other. My thought would be the following. You know, United States, only select centers have it because they're very expensive. But if you do have resources and it's available, my thought would be at least give a DCB a try. And if they have recurrent ISR, then try another strategy, which would be a stent.
Do you check any OCT after Rota ablation for the calcified ISR to see the damage of the stent?
So with rotational atherectomy, it's, number one, it does some degree of debulking. But I think the plaque modification is something that's not always readily visible. With IVL, it's clear, you see fractures. But with rotational atherectomy or even orbital atherectomy, it's more modification. I don't think the calcium and how you ablate it or modify it is not obviously or very obvious at the time you do OCT.
Okay, Dr. Ali, I have one simple question. Do you routinely use guide eccentric catheter to pass the IVL balloon in such kind of calcified lesion? Because I think in those regions, Rota ablation would be another good option.
So virtually every case. We open it at the beginning, we take a semi-compliant balloon, inflate it in the lesion, suck the guide liner in or through the lesion, and then unsheath or advance the IVL in. We rarely need to use atherectomy to now cross. If a 1 millimeter Takiro balloon actually crosses and makes enough space and you can get your guide liner, the IVL will cross.
So you show we need some extent of a calcium arc for indication of the IVL. So how about the calcium nodule?
Yeah. So
calcium nodule may be less than the very small calcium arc. So maybe not effective than the concentric region.
So we actually published this data in JACC intervention, and for the acute outcomes and the 2-year outcomes are actually in press in your intervention. So actually IVL works extremely well. The key is to put the emitter on top of the nodule. And so what happens is, you might impact the nodule itself, but you can modify the calcium that's around the nodule. And then, as Akiko probably showed you, you make the nodule compressible and deformable. So it's actually, there's nothing great for nodules, but it's highly effective. We just had a paper accepted. I can give you a very important tidbit of information. When you have a minimal lumen area at the maximum calcified site of 2.5 millimeters or less, atherectomy can debulk up to 50% of your nodule. But if your minimal lumen area is more than 2.5, you can only debulk approximately 10%. So when the MLA is big, your best strategy is upfront IVL. If your MLA is small at the max calcified site, a big burr or orbital atherectomy is highly effective.
Okay.
When I look at the image, is the crack through the intima to the almost be adventitial. Is the calcium thickness is quite longer. So I think it's quite different. Usually we do the high pressure balloon or Rota ablation, and the predominant side of the fracture is between calcium and the normal segment. But the IVL is just middle of the calcium is a different mechanism of energy delivery.
So in eccentric calcification, if you have the emitter placed in the middle of the calcium, you won't tear the fibrous calcific interface. You will actually break the calcium in the middle, like chopping, like a karate chop.
Could I share a short comment? We did a lot of IVL and think it's a good treatment. In our experience, we found that it's very effective in eruptive calcified nodule. But in non-eruptive calcified nodule, even Rota and then followed by IVL, the effect is still very limited.
So a non-eruptive calcified nodule is already broken, right? It's broken by biology. You have a piece of glass, the artery's bending, the glass breaks, you have intraplaque hemorrhage around it. So even a non-compliant balloon or something will push the non-eruptive nodule out of the way. The problem is because the glass shards are already broken, they have a tendency to push back into the stent over time, which Akiko showed very elegantly in our 250 patient series.
Okay, I have a question to Dr. Hahn. So in these master cases, we saw the many strategies, including the high pressure ballooning. So for the treatment of calcification, the effectiveness is important. However, safety is most important. From based on this concept, I think the super high pressure balloon had some concern of the most, how can I say, the most dangerous procedures. So however, the most convenient is comparing the Rota or lithotripsy. So what do you think some strategy for the safe use of the super high pressure ballooning?
We do not have IVF, so we only have a root ablation. So for severe calcified lesions, probably root ablation is a very essential step in Korea. But even if you do successful root ablation, there are some residual stenosis in my case. So if MLD is 2.0 or MLA is 2.5 square millimeter, in that case, the big bore root ablation does not work. So in the case in Korea, we have to rely on the super high pressure balloon. So I do not enjoy the use of OPN balloon, but some cases we have to.
Any other question or comment?
The final result of Dr. Han's case is after the super high pressure balloon, there is some perforation. The site is quite interesting. The counterpart in the severe calcium, it means that the high pressure balloon, supra high pressure balloon, perforation in the normal side, not the calcium side.
So usually that is eccentric calcium. Usually perforated side is a healthy size. So do you in the OA, orbital atherectomy is available in Korea?
Unavailable yet.
Michael, how do you think the OA is guide bias is good than rotational atherectomy for the inner curvature? So
that's one of the, I think, the advantages of orbital atherectomy in that with rotational atherectomy, what I've seen and what I believe is that once the burr passes, no matter how many times you go back and forth, you will continue to go down that path of least resistance. So you could do 20 runs, but you're not going to cause too much modification of the plaque. Whereas with orbital, because not only does it rotate, it also orbits. So I think you get 360 degrees of contact. So I think that's where the benefit is. Apart from the fact that it's much more versatile and that you just push a button and you go what amounts to about a 175. But that wire bias, because if you think with rotational atherectomy, the wire will basically go in the greater curvature. You won't have much ablation or modification of the lesser curvature.
I would like to ask to Dr. Veruna, in my experience, which could be deviated by my personal experience, but in my experience, cutting balloon has a blade, and it can so because of that blade, it should be more powerful to make a crack to the calcified area compared to the scoring balloon. And in that regard, scoring balloon could be more safe than the cutting balloon to the damage in terms of the damage to the non-calcified segment. What do you think about my opinion, and do you have any more further insight?
Yes, so the main question is, what is your intention for treatment of the lesion? So normally what we want to achieve is that we really crack the calcium, for example. And so I think in these points, the cutting balloon may be more effective than the scoring balloon. However, as I've shown, we have no comparative data available. So we actually don't know. We have a feeling that maybe with cutting you get more deeper cuts, but more dissection and more maybe situations, but we don't know from the data yet.
May I comment about that? It's quite interesting, and you know we use we consume around 1,000 cutting balloon in our institution per year, and actually with cutting I have more than 20-year experience, and as well with scoring balloons and as IVL and other devices. But this is quite interesting about escalation therapy. But if you look on cutting versus scoring, actually I would never to put them in one basket, because the mechanisms are completely different. And for this reason, we did it was not a big study, we did with Cleveland, with Hiram Bezarro and Marco Costa, the OCT study, but it was, I guess, a long time ago, some 12 years more. And then we seen very well, if you look on imaging, especially on OCT, there is completely different, I guess, not I guess, there was a completely different results and cracking calcium, and for this reason I guess the scoring balloons also, there is a place for scoring balloon, but as you mentioned and you show very well that it is really depends of plaque morphology. It really depends, but I would never, because usually we have a very big mistake, we put scoring and cutting versus plain balloon angioplasty. This is a huge mistake.
Yeah, I think it's a huge mistake. And the other very, very important point, it's really, really tough to find adequate endpoints for a study, because you are doing a lesion modification on the way, and afterwards, if you're satisfied, you put a stent in. So the endpoint of such studies is so difficult to define, so it's more or less impossible, and that's why we don't have good data available.
Absolutely agree, but what I also wanted to stress out that it's all devices, and they showed us very well this the data about IVL, it works if you have a real vessel dimensions, and then actually to treat a vessel with media to media, or doesn't matter, but this is so important. That's why we need to use more and more intravascular imaging, and then to actually to choose which device to use.
Okay, thank you very much. So unfortunately, it's time to close this session. Thank you very much for great presentations and great discussions. Thank you very much.